I am going to be talking about dentinal hypersensitivity. This is a common issue that you're going to see in your adult patients. In fact, 12.3% of the adult population experience dentinal hypersensitivity. You can see in this picture here that there is some recession present. This is what you're going to see in a lot of your adult patients. We talked last week about the OMG, the overlapping, meeting, or gapping of the cementum to the enamel on the crown surface, the cementum on the root surface, and the enamel on the crown surface. And in this picture, you can see that there's a little bit of a gap, and even if there wasn't, there's now a recession, which is exposing some of that root surface. Pretty common problem. Sharp pain, short duration, and in response to certain stimuli. Anybody can get it. It's very common in the 20s and 30s. So you look at your young person who you would deem to be healthier, and those are often patients who have dentinal hypersensitivity. Greatest incidence is 18 years to 44 years, and it is more predominant in patients who have periodontally involved dentition. When a patient is over 30 years old, the pulp chamber is going to be a little bit smaller, and there's going to be more reparative dentin that has been laid down. And the dentin tubules, which I have explained before, that the dentin tubules on a microscopic level are very porous. Those very porous dentin tubules will become filled over time. The root surface, as patients age, will become exposed due to recession, due to having that natural gap. And remember, we said that 60% of the patients have the cementum and enamel overlapping, 30% have them meeting, and 10% have a gap between the cementum on the root surface and the enamel on the tooth surface. So there's that dentin, which is the softer, more susceptible to decay area of the tooth that is exposed. We talked a little bit about abfraction when there's some flexion at the area right at the cervical of the tooth between the enamel of the crown and the dentin cementum of the root surface. When a patient flexes, there can be some enamel that shears off in that area. Periodontal surgery can cause the root to be exposed. Any restorative procedures can cause the root to be exposed. Orthodontic treatment can cause teeth to move and there to be some recession or root exposure. And if somebody is doing that scrubbing technique, the horizontal scrubbing technique, incorrect brushing can also lead to root surface being exposed. The dentin can be exposed, the lack of covering at that CEJ, the cemento-enamel junction. There can be a loss of enamel or cementum in that area. It can develop from iatrogenic causes, so clinician-induced. The hygienist can remove some of the cementum during scaling. Calculus can be removed, steen can be removed, a rubber cup polish or air polisher can remove some of the smear layer on the tooth. We have talked a little bit about the tooth having a smear layer that's made up of organic and inorganic debris that covers the dentinal surface and the tubules following scaling and instrumentation. So if that has been removed, a patient can have some dentinal hypersensitivity. The dentin can be covered with calculus, or the tooth surface can be covered with calculus, and then when the hygienist scales the calculus off, all of a sudden those dentin tubules are exposed and become sensitive when that calculus that was covering and protecting and keeping the area covered, it can become sensitive when it's uncovered. Here's a picture where we've got the dentinal fluid in the dentinal tubules. And when those dentin tubules are exposed from abrasion, so that's a toothbrush abrasion or a brushing abrasion, attrition, tooth-to-tooth contact, erosion, which is a chemical removal of the enamel or dentin surface, or abfraction, which is that shearing off of the enamel in the cervical area, a lot of the times due to pressure on the tooth surface biting. Here's the dentin fluid that is in the dentin tubules. Here's our odontoblast, specifically our odontoblastic process that is in the dentin tubule. And there's a fluid shift when those dentin tubules are open and more porous. And that fluid shift, called the hydrodynamic theory, can shift the fluid in and out of the open dentin tubules, the porous dentin tubules that are on the root surface. Patients can have dental hypersensitivity from gastric reflux. So anybody who's got stomach issues, severe heartburn, GERD, anyone pregnant who has morning sickness, they can have some dental hypersensitivity. If there is somebody who is anorexic or bulimic, they can have some self-induced vomiting, which causes dental hypersensitivity. Somebody who works in an industrial area where there's acidic aerosols can have sensitivity. Diet, you can have sensitivity from carbonated beverages, citrus fruits, excessive intake of either one of those. Usually the symptoms that the patient talks about, they'll complain about sharp pain. It'll be brief, goes away, pretty localized. On average, a person in that 12.3% range that experiences dentinal hypersensitivity will have an average of 3.5 teeth. So 3.5 teeth that they can point to and point out that that tooth is causing them sensitivity, or that tooth is sensitive for them. It's usually short duration, but it can linger as a dull ache. There's differential diagnoses. We want to make sure that we're not just blowing something off and attributing dentinal hypersensitivity as a problem, and maybe recommending sensitive toothpaste or more minor treatment when it is pain due to caries. Pain due to caries is going to be triggered more by heat. It's going to linger. It may be constant. It may be throbbing. It may keep them up at night. So we want to ask good questions to make sure that it is a dentinal hypersensitivity pain, that it's brief, that it's to cold, that it's to air, and that it's not a caries or an abscess type of pain. The stimuli that trigger the pain for dentinal hypersensitivity can be just toothbrushing. Something touches that tooth surface. I've had patients who I've been cleaning their teeth and I come across the cervical area just with my instrument and they go, ooh, I felt that. Sometimes eating utensils, dental instruments, like I just said, denture clasps, clasping around a tooth in that area of sensitivity. Some of their oral habits, they might use toothpicks or they might use proxy brushes and have some sensitivity on certain areas. Chemical, again, the citrus fruits, wine, carbonated beverages can all make a sensitivity issue more prevalent. You can, if they eat or drink something cold, brush across it, eat an orange, eat tomatoes, drink some carbonated beverages, they will get pain, and it can be attributed to the dentinal hypersensitivity. It's not really a pain that is able to be distinguished like, oh, that was a little cold sensitive, oh, that was toothbrush sensitive. It's just pain. It all registers as pain. More triggers are thermal, mostly cold versus hot. Hot is usually more of a pulpitis type issue. Different foods, air, breathing in. I remember, and I have told you guys before that I have sensitive teeth, use sensitive toothpaste on a regular basis. I was running in a race in the UP in a 5K, and it was below zero, had a scarf, started to run, and my teeth were so bone-chilling cold, and it was so sensitive. I could hardly open my mouth to breathe because the air was bothering my teeth so bad. Another thing is when you're using a suction and you're kind of has some air current going across the tooth surface, that can bother people. So I've been an assistant where I'm helping the dentist do a crown prep, and there's a tooth that's, we're doing a crown prep on the bottom, and there's a top tooth, or we're doing a crown prep on the top, and there's a bottom tooth that is just killing the patient due to the sensitivity just from the air and the dehydration of the oral fluids in that area due to the suction. So we've had to sometimes numb other areas so that the patient can make it through a crown prep on the opposite arch. Osmotic is the pressure change in the dentin tubules. So this is the flow of the liquid in the tubules that's caused by just the concentration of the potassium and sodium ions going in and out of the dentinal surface. Pain is what the trigger, or what you feel. Any of those triggers, there's a whole list of triggers, but the patient feels pain. The pain impulse transmission to the pulp as a result of the fluid movement within the dentin tubules stimulates the nerve endings at the dentinal pulp interface. So you've got this hydrodynamic mechanism where the stimuli, the pain impulse comes from the stimuli of just the fluid movement going in and out of those open, porous dentin tubules and stimulating the nerve endings at the dentinal pulp interface. The body is an amazing thing. It does a lot of things to improve the conditions just on its own. There's reparative dentin that's formed along the pulpal wall as a protective mechanism in response to trauma or irritation. This is going to be more like when caries is starting to get close to the nerve of the tooth. It's going to kind of back up and put some reparative dentin down to protect the pulp of the tooth. And in the meantime, hopefully you get that caries area fixed, and the tooth has kind of helped protect itself. Secondary dentin is secreted slowly over time after root formation to wall off the pulp from fluid flow from within those tubules. There are minerals deposited back into that recession, that area of recession. So from fluoride, from minerals from your diet, from your toothpaste, from your saliva, even calculus deposits are made up of a component of hydroxyapatite. So those minerals will go back into the porous dentinal tubule area to help protect the tooth, and the body's kind of protecting it itself. Any dietary changes, avoidance of trigger foods. One thing that really, really makes my teeth sensitive is eating ice cream. So great, that would be a good reason not to eat ice cream. If I eat ice cream and my teeth are very sensitive, I shouldn't eat ice cream. No. Instead, I've come up with the fact that if I put my ice cream in the microwave for 12 seconds, then it's not cold enough to quite give me that same painful impulse. So I could totally avoid it and that would be good, but 12 seconds in the microwave and I'm good. Now, some of the professional treatments that we have are going to coat the tubule openings. They're going to cause the dentinal tubules to mineralize or have a precipitate form within those tubules. And the irritation of the recession areas and the fluid movement in and out is going to stimulate the tooth itself to form that secondary dentin. We want to try to interrupt the nerve transmission, and hopefully there's enough secondary dentin formed and precipitate put into the tubule. And you can see the top picture here is that more open microscopic look of a very porous area that certainly would be a lot more sensitive than this bottom picture that has some precipitate that's formed and some mineralization that has covered the openings to the dentin tubules. In the clinic, let me go back for 1 second. In the clinic, we have 2 different dentin hypersensitivity treatments that we use. We'll be introducing those in dental materials this summer, and you'll be using those on each other so you'll know how they work. They're located in the sterilizing area, second cupboard back. One is placed on the tooth with a brush. It's dried, it's reapplied, and then dried again. And there's a precipitate that forms in the tubules to protect the tooth. The other one that we have is brushed on and light cured to occlude or block those dentinal tubules. Those are two different methods that we use in clinic. And the one thing that I do, if I ever use something like that on a patient, I write it down in their notes, which of course, anything that we do, we should write down and document in their record in the clinical notes. But I want to know if it worked. So I want to know 3 months later. I want to know 6 months later. Did that work? Did that give them some relief from the sensitivity? Is their sensitivity gone? Did they even notice that one of these treatments worked or didn't work? I want some feedback from the patient. So I will usually record what I did or what I told them, what I recommended, so that I can ask questions and see what kind of response they got. Fluorides that we give them in the clinic, fluorides that we recommend at home, can help occlude or precipitate in these dentin tubules and block those dentin tubules, either way that we do it, whether it occludes over top or it precipitates so it mineralizes within. Either one of those can help control some of the dentinal hypersensitivity. There's going to be blockage of the tubules with certain toothpaste ingredients. We've already looked at some of those toothpaste ingredients, being strontium chloride, potassium oxalate, ferric oxalate. Those will all block the tubules. Then there's some physical blocks that we can use. So varnishes, our fluoride varnish, bonding adhesives. One of the dentinal hypersensitivity treatments that we use that's light cured is kind of like a bonding. So it bonds over and covers the dentinal tubules. Resins, seal and protect, are different physical blocks to the stimuli. And then there's fluoride and strontium chloride in pastes. There's gel cam rinses. There's a lot of different products that can work. And if we're using one thing and we suggest one thing to the patient and it doesn't work, then we try something else. Then we try something else. Ionophoresis is an electrical current that puts the fluoride ion deeper within the dentinal tubules. Calcium hydroxide can be placed to increase the peritubular dentin mineralization, and it can occlude the opening. It's kind of burnished into the surface, and it takes several applications to potentially block the tubules. Lasers can be used. They can close previously open dentin tubules and alter the tubule contents through coagulation of proteins with precipitate. They call dental laser therapy melting and resolidification. And then hypnosis. I'm not sure how hypnosis fits in here, and I think I need to probably take this off the slide. Hypnosis, so we hypnotize you so that you are not feeling the dentinal hypersensitivity because we're telling you and hypnotizing you that you're not feeling it? I'm not sure. Plaque control is very important. So we want to make sure that we're not demineralizing these areas that already have more open dentin tubules, that already have recession. Remember, our critical pH of the root surface is 6.0 to 6.7, and that's a lot more susceptible to decay. So if we add plaque to that area and demineralization starts to occur, the patient is going to be more sensitive because that area is going to be more broken down. Another thing that we really want to keep in mind is patients come in and they want whitening. They have periodontal disease, they want whitening. They're missing teeth, they want whitening. They have cavities, they want whitening. They have sensitivity, they want whitening. Whitening may be contraindicated for patients with dentinal hypersensitivity. So we want to make sure we have that discussion with patients. For the patient-applied dentifrices, we've talked about potassium nitrate being one of the ingredients in sensitivity toothpaste that blocks nerve conduction and prevents nerve depolarization. That compared to the strontium chloride, which blocks the tubule. That can be in self-applied fluoride, and also recommendations for diet changes, which is kind of why there's a bigger dot there, is diet changes. If a patient is having a very acidic diet, we want to discuss that with them. If they're a pop drinker, we need them to cut down or reduce the sodas that they're drinking, the pop that they're drinking. And if they are getting dentinal hypersensitivity because of juices or lemon juice in their water, we want to find out like what the triggers are that are causing them dentinal hypersensitivity. Now remember that when we're in class, I mentioned that it could take up to 2 weeks for sensitive toothpaste to start working. So we want to make sure that they know that if we give them a sample at the office of Sensodyne, Colgate for sensitive teeth, Crest for sensitive teeth, that it could take up to 2 weeks for those sensitive toothpastes to work. And during that 2-week time period, if they get relief, that's great. It could be that they're having pain and it's something as controllable or as easily fixed, I'll say, as dentinal hypersensitivity. You use a sensitive toothpaste, you regularly use a sensitive toothpaste, that kind of takes care of the pain. When we are first diagnosing the dentinal hypersensitivity, we want them not to use the toothpaste for longer than 4 weeks. We want to make sure that we're not masking another problem with the sensitivity toothpaste. So we want them to use it for 4 weeks. If they move away from it and they have a tooth that flares back up, they need to come back in and see us. If somebody has chewing pain, if they have pain from pressure, occlusal pressure, that is usually another problem that can be indicative of pulpal pathology. And we want to make sure that we're not covering up something like that that is leading to an abscess, leading to infection with the patient using sensitive toothpaste long term. Once we determine that it is dentinal hypersensitivity, patients can be using sensitivity toothpaste on a regular basis indefinitely. Like for me, I use sensitive toothpaste all the time. If I go away from it, my teeth become sensitive. If I go back to it, my teeth are not sensitive. I get regular x-rays and regular examinations and know that there's not an underlying problem that is masking. So that would be the goal with patients, is to determine where their pain is coming from and help them be able to manage that pain, whether it be through in-office treatments or the different dentinal hypersensitivity treatments that block or occlude the dentin tubules so that there's not that hydrodynamic theory and the pain that comes with dentinal hypersensitivity. All right, great job.